We all know that low back pain is a common problem and costly burden to society. There are many promising treatments for chronic low back pain. The most commonly recommended treatments in national guidelines are exercise and cognitive behavioral therapy. But what about spinal manipulative therapy? Spinal manipulation is something we as chiropractors use for this condition, so what does the literature say? Hello, my name is Sidney Rubinstein. I'm an associate professor at the Vrije Universiteit in Amsterdam. I would like to present the results from our review published in the British Medical Journal, which examined the effect of spinal manipulative therapy for chronic low back pain. In order to best summarize the literature, it is important to approach it systematically. As clinicians, we're only too happy to cite those studies which demonstrate that spinal manipulative therapy is an effective therapy, but tend to ignore or even find fault with those studies which cast doubt on its effectiveness or suggest that other therapies might work better. Systematic reviews summarize all the available studies and thus represents more accurately how an intervention might work in clinical practice. But before we proceed, I feel that it's important that you understand the difference between a systematic review and a meta-analysis. Systematic reviews typically include a meta-analysis, so what is this exactly? Well, a systematic review is nothing more than a summary of the evidence, meaning it is a summary of all the available studies. A meta-analysis, on the other hand, is the statistical technique used to summarize that evidence. Therefore, a meta-analysis represents only a small part of the review process. The major advantage of a meta-analysis is that it allows us to combine or pool the data from individual, comparable, randomized controlled trials, whereby the results can be expressed as a single unit or number, as you see here, circled in red. For example, it allows us to express by how much pain has been reduced, or indicates by how much functional status or disability has been improved. So, for example, we can say that spinal manipulative therapy has reduced pain by 5 points more than a given comparison therapy at a specific time interval, for example, at 3 months follow-up. This quantitative summary gives us a better feeling for how an intervention, such as spinal manipulative therapy, might work. However, it may not always be possible to combine or pool the data because the studies differ in some fundamental ways. Because, for example, the duration of low back pain or the population is very different in the individual studies. In this case, a single statistical measure might not accurately reflect the results of the individual studies. Well then, why this update? Our previous review was based upon studies which were last published in 2009. Since then, some important publications have appeared which I want to share with you today. 2009 might not seem so long ago, but I want to put that in perspective for you. For example, in 2009, Barack Obama had just been sworn into office. Nokia was still one of the leading mobile phones on the market, and the United Nations had just held its first climate change conference calling attention to this enormous global problem. So what did this update teach us that we didn't know previously? What have we learned? But perhaps more importantly, where do we currently lack knowledge? Before presenting those results, it is necessary to briefly explain the methods so it is clear for everyone how we conducted this review and what decisions were made. We examined the effect of manipulation stratified by the different types of possible comparison therapies. That is to say, we examined the effect of spinal manipulation compared to recommended therapies, such as exercise or general practitioner care. We also examined the effect of spinal manipulation compared to non-recommended therapies, such as ultrasound or diathermy. And examined the effect of spinal manipulative therapy compared to sham or placebo manipulation, although you can ask yourself what a sham treatment might look like, and whether patients could be deceived by this type of study design. We placed no restrictions on the type of spinal manipulation, so we included studies which examined both the effect of high-velocity, low-amplitude manipulation and low-velocity, low-amplitude mobilization. We looked to see if there was a difference between these two types of treatments, and I will discuss those results later. We also placed no restrictions on the type of clinician, so we included studies in which manipulation was delivered by chiropractors, manual therapists, or osteopaths. We focus on two outcomes, pain and functional status, because these are the outcomes typically reported and are a good measure which reflects how manipulation might work. Pain was typically measured on a 10 or 100-point scale, using a visual analog scale or numerical rating scale, and functional status was typically measured by the Rowan-Morris Disability Questionnaire or the Oswestry Disability Index. These scales give a good indication how much the back pain influences the activities of daily living. In this update, we identified 21 new studies totaling 47 randomized controlled trials representing more than 9,000 participants. Think about it, more than 9,000 participants. That is quite a large sample. So that allowed us to draw some important conclusions. By far, most of the studies examined the effect of spinal manipulative therapy versus recommended therapies. These were also the better quality studies. For example, in virtually all the studies, the randomization was conducted properly. Randomization helps prevent an important form of bias, known as selection bias, which could otherwise negatively affect the results. However, in these studies, none of the subjects were blinded to the treatment they received. That is to say, the participants knew whether they were receiving spinal manipulation or the comparison therapy. So that could potentially affect the results depending upon how patients feel about the therapy they received. So, for example, if a participant was randomized to exercise and had a preference for spinal manipulation, that participant might rate his outcomes more negatively than someone who had a preference for exercise who was randomized to exercise. By comparison, less than half of the studies examined the effect of spinal manipulation versus non-recommended therapies, such as ultrasound or diathermy. Importantly, in some of the studies, it was unclear whether the randomization was conducted properly. Finally, relatively few studies examined the effect of spinal manipulative therapy versus sham or placebo manipulation. These studies were by and large poorly conducted. Furthermore, an essential feature of sham-type studies is that patients should not be able to determine whether they received the real or the fake treatment. In pharmaceutical trials, it is easy to blind patients, so they don't know whether they're receiving the effective therapy or a sugar tablet. In trials of spinal manipulation, it is trickier. Therefore, it is questionable what these types of studies add to our knowledge. So most of the studies were pragmatic, and that is where we will focus the rest of our attention. So back to our questions. What have we learned from this update? But perhaps more importantly, where do we currently lack knowledge? Well, we have learned that manipulation and mobilization are equally as effective as recommended therapies, such as exercise or standard general practitioner care for the treatment of chronic back pain. That might not sound so impressive, but if one examines the recent Lancet series on low back pain, which summarizes international guidelines from Denmark, the United States, and England, it would appear that spinal manipulative therapy is not recommended as a first choice, while the results from our review suggest that spinal manipulation is certainly on par with other recommended therapies, such as exercise or cognitive behavioral therapy. This is perhaps understandable. Chiropractors are typically not included in guidelines commissions, so spinal manipulation is typically not included in their considerations. Perhaps most importantly, spinal manipulative therapy is often seen as a passive therapy, whereas the goal of treatment should be to empower patients. That is, patients should be provided with the tools to solve their low back pain on their own, and with minimal intervention from us, the healthcare provider. Nevertheless, these results suggest that spinal manipulative therapy is just as effective as exercise for reducing pain and improving function for patients with chronic low back pain. Having said that, we identified a problem during our analysis. Spinal manipulative therapy does not demonstrate clinically better results when compared to non-recommended therapies or even sham manipulation. This is an important dilemma which is difficult to understand. One might think this is due to poor quality studies, but poor quality studies are only likely to exaggerate the effect, not minimize it. In other words, poor quality studies would favor spinal manipulation, not sham or non-recommended therapies. Perhaps most importantly, there were far fewer of these types of studies, therefore we have much less confidence in these effect estimates. so future studies are likely to influence how we view this. We address this exact point in a letter to the editor of the British Medical Journal, and I refer you to their website to follow that discussion and read our reply. We also learned that spinal manipulation works better for improving functional status than for relieving pain. I think this is also consistent with the working mechanism of spinal manipulative therapy. One of the hypotheses is that spinal manipulation is designed to restore motion where it is dysfunctional or where there is aberrant motion. Restoring motion allows our patients to function normally again, whereby the pain diminishes over time. This is a different paradigm than immediate pain relief. Clearly, spinal manipulation doesn't work like a pain reliever, such as aspirin or paracetamol. We've also learned that spinal manipulative therapy is a safe treatment. Many of the adverse events observed in the trials we included were musculoskeletal related, were of short duration, and were moderate in severity. Having said that, admittedly, trials are not the study design of choice when examining adverse events. If one's focus is to look at complications of spinal manipulation, it would be necessary to recruit hundreds, if not thousands, of patients and follow them over time. Furthermore, adverse events were reported in fewer than half of the trials which we examined. But more importantly, in most cases, these studies did not use standard methodology, so it is questionable whether these results are an accurate reflection of clinical practice. Nevertheless, these results appear to be consistent with large observational studies. Finally, serious adverse events, such as Cauda-Equina syndrome or precipitation of a lumbar hernia, are extremely rare. So in short, spinal manipulative therapy would appear to be a safe treatment. We have also learned that there is no difference in effect between professional groups. So it doesn't matter whether spinal manipulation is conducted by a chiropractor, manual therapist, or an osteopath. Having said that, it is important to realize that these results are based upon indirect evidence. That is to say, no single trial has ever examined the effect of spinal manipulation carried out by the type of professional. Nor is this likely ever to be funded, because it's not in our interest, nor in the patient's interest to investigate this. If we look around us at other comparison studies, we see that the differences between groups are typically quite small, meaning it is difficult to demonstrate a clinically relevant effect, assuming that that might exist. Why this might be is a topic for another discussion. We've also learned that manipulation is equally effective as mobilization. This is based upon direct evidence. That is to say, 4 studies of good methodological quality where studies of manipulation and mobilization were compared to one another. This is in contrast with results from an earlier review published in the Spine Journal, which suggests that manipulation is more effective than mobilization. But those results were based upon indirect evidence, that is inference, but not based upon studies in which these techniques were compared directly to one another. So that is what we have learned from this review, but perhaps more importantly, where do we currently lack knowledge? Well, for the other outcomes, such as perceived recovery, return to work, or quality of life, there is insufficient data to determine the effect of spinal manipulative therapy with any confidence. If we think about how spinal manipulation works, it is likely to play a greater role in pain reduction than return to work, because return to work or quality of life are affected by many other factors, such as the work or social environment. If we were interested in getting patients back to work sooner, we would have to include spinal manipulation in a much larger package, where attention is paid to other aspects, such as the psychosocial factors. And I think that makes the problem clear. Chronic low back pain is a complex issue. Low back pain is affected by a number of factors. We also don't know whether spinal manipulation is cost-effective. Of the 47 studies which we identified, only 2 studies performed a proper economic evaluation. One of those is the well-known UK BEAM study. However, if we look at other studies wherein manual therapy is compared to physiotherapy, those who undergo manual therapy typically need fewer treatments. So it is likely that spinal manipulation is cost-effective. We just don't have that body of evidence at this moment to say that definitively. We also don't know which patients are most likely to benefit from spinal manipulation for chronic low back pain. we recently conducted a so-called individual participant data meta-analysis in order to identify the moderators or factors likely to influence the effect of treatment. But we were not able to identify any significant factors, so it remains questionable who is most likely to benefit. However, what we know in general is that those with chronic conditions or psychosocial factors, such as fear or depression, are less likely to respond to treatment. But this is not specific to spinal manipulation, so at least for now, it remains unclear who is likely to benefit from our care. Take a moment to think about this. Do you know which patients are likely to benefit from your treatment? Be honest. Can you say with any certainty, following the history and physical examination, which patients you are likely to help? If you're like me, in many cases, I am uncertain whether I can help the patient, despite an in-depth history and physical examination. This is also supported by the literature, indicating that it's difficult to predict which patients are likely to benefit from our care, despite our best intentions. Finally, we don't know how spinal manipulation works for other populations, such as the elderly. It is likely that the elderly with degenerative spinal conditions will respond differently than younger patients, or those with comorbidities, such as depression, diabetes, or obesity. This update of our previous Cochrane review probably won't change the way you practice nor affect your life very much. However, this review can facilitate conversations with other healthcare professionals, policymakers, and governmental agencies where chiropractic care is brought into question. At the very least, no one can say that there is no or insufficient scientific evidence for what we as chiropractors do. To summarize, we found spinal manipulative therapy to be equally as effective as recommended therapies for the treatment of chronic low back pain. Therefore, this publication can be used to better position chiropractic care where it is not currently accepted. Perhaps most importantly, it can help convince those who are skeptical. Lastly, research cannot be conducted without financial support. I would like to thank the Netherlands Chiropractic Association, the European Centre for Chiropractic Research and Excellence, and of course, the European Chiropractic Union for the support of my work. I hope you enjoyed this presentation, and I thank you for listening.